Hello, welcome to my audio medical basics to listen to when you don't have the free hands or free time to hold a book. If you like, please don't forget to like, share, and subscribe. Today I will be reading another case from my case files book collection. And today I will start with another book from my collection of the case files series. Last time I did the internal medicine, today we do the emergency medicine. We will do 3 cases from this book, as we did with the internal medicine book before. And we will do 3 cases before we move to the next book. And as done previously, each case may take 2 or 3 videos to be fully covered. Okay, all right. So first case we will start with in this book is the case of a case of hemorrhagic shock. Car accident. The car veered away. The man flew off the car. Okay. So again, I will do the summary because the full case is very long and the case itself will be revealed during the, case. So, a healthy 23 years old man presents following a motor vehicle accident with mild tachycardia, scalp laceration, femur fracture, and possible intraabdominal injury. The patient was also hypotensive and his CBC was stable. So, the next step in management of such patient. So, 23 years old man, following motor vehicle accident, findings were mild tachycardia, scalp laceration, femur fracture, and possible intraabdominal injury. Next step, of course, the airway, breathing, and circulation are always the first steps in the evaluation of trauma patients, ABC. In this patient, the ABCs have already been assessed, and the secondary survey revealed abdominal pain and a likely right femur fracture with intact pulses. The ultrasound examination demonstrated free fluid in the hepatorenal potential space known as Morrison pouch. Presence of fluid in Morrison pouch indicates intraabdominal solid organ injury with concomitant hemorrhage. The patient was hemodynamically stable, and a CT scan of the abdomen and pelvis should be done to help identify and quantify the injuries. The CT scan was not done yet for this patient as of this case. The CT should be useful to estimate the amount of intraperitoneal free fluid and to identify the source of bleeding. Another question was that presented with this case: what is the most likely cause of hypotension in this patient? The patient was hypotensive. The most likely cause is hemorrhagic shock, which is the subject of the case today. The key areas of blood loss in this patient are his injured femur, intraabdominal injuries, and possibly from his scalp laceration. Other possible causes or contributors to his hypotension are cardiogenic shock secondary to myocardial contusion, or spinal shock secondary to injury to the spinal cord. The latter can easily be ruled out during the neurological examination. Analysis. So the objectives of this case is to learn the basics of initial assessment of a trauma patient, to learn the definitions and pathophysiology of shock and hemorrhagic shock, and to learn the advantages and disadvantages of base deficit, serum lactate, hemoglobin hematocrit, and pulmonary artery catheter application for shock identification and patient resuscitation. And finally, to learn the initial approach to managing and treating the patient with hemorrhagic shock. So, initial assessment of the trauma patient. The first priorities in the evaluation of any trauma patient are the ABCs. Asking the patient to state his or her name, followed by a rapid assessment of the presence of tracheal deviation, is the first step in examining the airway. If the patient is unable to protect his airway because of confusion, loss of consciousness, or an extrinsic threat to the airway, for example, expanding neck hematoma, the patient should be intubated with an endotracheal tube. Breathing is further assessed by listening to the chest for the presence of equal bilateral breath sounds and by observing the symmetry of chest wall expansion. The unstable patient with clinical signs of pneumothorax or tension pneumothorax is treated with immediate placement of a chest tube or needle decompression. Circulation is assessed via the vital signs and by palpation of bilateral, femoral, radial, or pedal pulses. Any suggestion of cardiovascular instability requires immediate intravenous access, specifically with 2 large bore peripheral IVs. Do you hear this? It's called, I'm rubbing my hands while I'm talking. I forgot to wear my coat. Sorry if you can't hear anything. Next, the patient's ability to follow commands should be evaluated, and an overall assessment of his or her level of functioning should be made. This consists of assigning score on the Glasgow Coma Scale. All of you remember the Glasgow Coma Scale? Well, it ranges from 3 to 15, and subsequently, a focused history should be quickly elicited, and the secondary survey follows, in which the patient is examined from head to toe. In the presence of severe obvious injuries, it is appropriate to start the examination at the affected sites. It is appropriate to start the examination at the affected sites. Additional history from paramedics and emergency medical technicians should be elicited. In this patient, the entire history is very concerning. In addition to being ejected from a vehicle involved in a collision at high speed, raising concerns for multi-system injuries and significant kinetic energy transfer, the patient was found 1 hour following the incident. The patient was found 1 hour following the incident in our case. That was mentioned in the long case. He was ejected, he was found 1 hour later. This guy over here. The risk for hypothermia and the diminished ability to respond to hemorrhagic shock is great. So, approach to hemorrhagic shock. Definitions. Shock. Shock is insufficient cellular perfusion. Shock is insufficient cellular perfusion and inability to deliver sufficient oxygen to the tissues. Hemorrhagic shock is inadequate tissue oxygenation resulting from a blood volume deficit. In this situation, the loss of blood volume decreases venous return, cardiac filling pressures, and cardiac output. End organ perfusion is subsequently decreased as blood flow is preferentially preserved to the brain and the heart. So, clinical approach in such patients. In shock, the lack of oxygen available to cells results in an inability of mitochondria to generate adequate ATP. Instead, anaerobic metabolism dominates, leading to an accumulation of pyruvate that is converted to lactate. Shock is divided into 3 stages: compensated, progressive, and irreversible. So shock is initially compensated by control mechanisms that return cardiac output and arterial pressure back to normal levels. Within seconds, baroreceptors and chemoreceptors elicit powerful sympathetic stimulation that vasoconstricts arterioles and increases heart rate and cardiac contractility. After minutes to hours, angiotensin constricts the peripheral arteries, while vasopressin constricts the veins to maintain arterial pressures and improve blood return to the heart. Angiotensin and vasopressin also increase water retention. So angiotensin and vasopressin also increase water retention, thereby improving cardiac filling pressures. Locally, vascular control preferentially dilates vessels around the hypoxic tissue to increase blood flow to injured areas. The normal manifestations of shock do not apply to pregnant women, athletes, and individuals with altered autonomic nervous system. Older patients, those taking beta blockers. All right, this is all for part 1 about the hemorrhagic shock case. And inshallah, we'll continue in part 2 about the clinical approach of the hemorrhagic shock case. Thank you very much for watching. I say thank you.